All right, so here we are doing the work to try and better integrate community care and hospital care so that every pregnancy and birth are safe everywhere. So we're going to kind of re-ground ourselves in the three delays framework as we have done every kind of time here, right? The community integrated maternity care models, the preventable morbidity and mortality are often related to one or more of these delays. The last two sessions of these, we've focused on these first two delays, the first being kind of in the community setting that we highlighted, the second, our EMS session. We highlighted some of the delays and just like ways to engage with EMS. And then today we're really focused on the hospital side of things and receiving care after reaching the facility, what delays can arise there, how drill planning can help us minimize those delays, and any other tools and strategies. So we want to take an opportunity to hear from some of the team members we've invited to join us today on what some of these delays can look like, and if there's any, stories or strategies and tools that our experts are bringing to us that they've seen come up that can minimize these delays, or kind of how to work through these specific delays in the hospital context.
I was the director of nursing. I also been a staff nurse, and one of the biggest delays was in getting a good report and knowing what to expect. How do we manage that call? And then having policies that prevent the person that has been taking care of the patient very closely for a long time, preventing them from being with the patient, and also not knowing how to manage with the baby if the mother's coming in with the baby. And a lot of those things came out of the drill that we did last week. And so I see a lot of the delays at the hospital side are partly because of the structures haven't been put in place. We haven't had good policies, and practicing those policies, and those policies are not collaborative. And so I see that as like um, uh, needing to have these relationships. So these drills really make a big difference in helping break down some of these easier to break down barriers. And some of it is just not having thought through what systems will work best for everyone. In the drill we ran a couple of weeks ago, the patient also felt everybody just staring at them as they came in, and it was a drill situation. And so there wasn't this like welcoming feeling of a patient who really didn't want to be in a hospital to begin with. Those are human factors. And then the other way I look at it is like non-human factors. How do we just get all of those equipment and systems in place? And I'll just pause there because I'm sure others have other insights, but those were just some things that I thought would be helpful to point out.
I'll share my experience. And so both from a staff nurse level on the acute side and as a director, I'd also say that some of the solutions as I became a nursing leader, that I think are important for us to focus on too as we go forward is how do we build collaborative relationships? And so, getting out of the acute setting and visiting, when I met Amy, it changed my life because I had a different understanding of birthing centers and community birth, and did some work in Michigan around that as well with understanding what happens at uh, birth centers. And so getting to those settings, seeing them, meeting the staff, understanding that actually we have a lot of shared goals. We all want the best outcome for mom and baby. And so where do we start to build those relationships? And then on the other side, doing some work to invite community doulas into the acute setting, invite midwives who practice in the community, so we can really understand your training, your roles, because there's a lot of misconceptions about what you have done and what your roles and credentials are, and so that we can all focus on the experience that you bring to the table. I think, again, to speak to what Deb said, that will foster understanding of what do we need to know on the phone when you accept that transfer. And it's a lot easier when the person on the other side has a face and you actually have met each other, because we all know it's hard to disrespect when we're in the same space.
you know, um, when there isn't a pre-existing relationship between the community provider and the hospital, then that game of telephone literally breaks down. And there are so many phone calls that need to be made. You know, if you are using EMS, then you're calling 911 first and getting the vehicle. And sometimes there's magic words you need to say to get them to dispatch right away, even as you're giving the report to the dispatcher. You know, when you have those relationships and you know who to call and what to say, then that can really minimize your delays. And when you don't have those phone numbers or those relationships, then, you know, the real clinical scenario truly is lost in a game of telephone. And that contributes to delays in all three phases of care. One of the other things I wanted to bring up too is that, you know, especially when it comes to delay number 3, which we're highlighting, that, you know, you have compounding of delays from 1 and 2 that kind of land on the hospital, but aren't necessarily because of anything hospital related. So you have a delay from, phase number 2, but it then creates an even bigger delay in number 3. And so thinking about how these pieces all relate to each other, I think is really critical.
I add one more piece, and it came up in the drill last week, was that that the midwives can have a strong enough relationship. They actually have the patients registered, so they're known to the hospital. So they talked about there's more delays if a patient's unknown to the hospital versus known to the hospital. And I love that, thinking ahead as a midwife, okay, what is my backup plan? And how do I have this patient known to the hospitals, and the blood work was even being done at labs that would make it possible for the hospital to have access to some of those labs. And that I thought was interesting, an interesting way to prepare for a potential transport way in advance.
Mm-hmm.
Thank you all for sharing. I think it's like you all hit on exactly what we want to be highlighting in these sessions. And this one in particular is just how the drills are critical to like identifying those delays and processes and procedures that like maybe you think you have in place, and then you test it and you really actually need to rethink it.
We are rounding out our focused action cycle this spring/summer on July 14th. So even if you have not been part of a drill, you're all very much welcome to come to this session where we will be doing our signature community debrief on, the drills that did happen during this cycle, but also talking about some quality improvement tools that can be utilized at any point in this relationship building process to really test your transfers and continue to improve safety and improve outcomes. And we'll be sharing more during that session.